This case is an example of recurrent vulvovaginal candidiasis. A woman presents with recurrent vulvovaginal candidiasis that has not responded to the standard azole therapy for vulvovaginal candidiasis. What is the most appropriate diagnostic test, or what is the most appropriate next step if the vulvovaginal candidiasis is not responding to the azole therapy, or it is recurrent, or it is invasive? The correct answer, the next step, is high vaginal swab for microscopy, culture, and sensitivity. Why? Because recurrent or resistant or invasive candidiasis is most likely to be caused by non-albicans candidiasis. That's why it doesn't respond to the standard azole, doesn't respond to the standard azole therapy for the Candida albicans. So, high vaginal swab for microscopy, culture, and sensitivity is the most likely next step to detect the non-albicans Candida, to confirm the non-albicans Candida, which may require alternative treatment. So the patient will start an alternative treatment. Okay, I will show you. This is the treatment approaches. Okay, antifungal medication for Candida albicans is different from the non-albicans. Candida albicans usually respond to azole antifungals as fluconazole, itraconazole. They are often the first-line treatment for superficial candidiasis caused by Candida albicans. However, the non-albicans species usually not respond to azole antifungal and may require echinocandins, may require a specific strategy. Echinocandins as caspofungin, micafungin, or amphotericin B. So here in this patient, recurrent or resistant candidiasis, resistant to infection or recurrent candidiasis, will require further investigations, high vaginal swab for different treatment by echinocandins. I will show you an example of invasive candidiasis, which will require echinocandins and amphotericin B instead of the standard therapy, azole therapy, for the superficial candidiasis. This is not superficial candidiasis, this is invasive esophageal candidiasis. A 42-year-old male with odinodysphagia. This is a kind of invasive candidiasis, odinodysphagia. This is esophageogram, demonstrates multiple contrast outpouching. This is the shaggy esophagus, okay? Multiple contrast outpouching along the esophageal wall, consistent with intramural pseudodiverticuli. So outpouching from the esophageal lumen into the wall, okay? Multiple contrast outpouching along the esophageal wall consistent with intramural pseudodiverticuli, consistent with esophageal candidiasis. Okay, another example. This is another example of esophageal candidiasis, which is considered invasive candidiasis, not superficial as vulvovaginal candidiasis. This patient has dysphagia and retrosternal pain, and this patient is HIV positive. This is very important. Invasive candidiasis, as esophageal candidiasis, is a common association or a common pathology seen in HIV patient or immunocompromised patient. Okay, so immunocompromised patient or HIV positive patients are susceptible to invasive form of candidiasis as esophageal candidiasis. Okay, so the findings here, another one. The barium swallow shows a longitudinally arranged, shaggy, serrated appearance of the middle and lower third of the esophagus with innumerable small filling defects, multiple tiny erosions, areas of ulceration, shaggy pattern of esophagus, multiple intramural filling defects or outpouching, multiple intramural outpouching or pseudodiverticuli, shaggy pattern, multiple linear filling defects, okay? This is the esophageal plaques or candida plaques giving this appearance. I just want to show you that the first line here, as Candida esophagitis is an AIDS defining illness in an HIV positive patient, okay, I will discuss the case urgently with the referring clinician, okay. So the first line here is fungal culture. So the first line or the first step of management in recurrent or resistant or invasive candidiasis is the fungal culture. Take a swab or fungal culture. Here is taken from the upper gastrointestinal tract for definitive diagnosis. So the diagnosis depends here on the fungal culture from the upper GIT tract. Okay. The first step here for recurrent or resistant candidiasis is to take a swab, high vaginal swab by for culture and sensitivity, for microorganism culture and sensitivity to detect what's happening here. High vaginal swab for microscopy, culture and sensitivity, MCS, microscopy, culture and sensitivity. Why the other options are incorrect? Urine tests are irrelevant, okay? Pap smear doesn't diagnose vaginal infection. Pap smear diagnose the cervical cancer or abnormal cytology of the cervix, okay? pH testing is often normal in candidiasis. Wet mount alone may miss non-albicans species.